Yeah, I'll take this. I'll take this. I use this mic. Exactly. I had about the slides. Yeah, I can just. Yeah, I think my need to advance it down. Oh, that's even better. Down. Hey guys, welcome back from the break. I hate to cut off the conversation because I know that it's so great to see everybody again. It's so great to be together.
Beat it, man, beat it. If Yankees come to Trinidad, some of the girls were more than glad. Young girls say they treat them nice. They Trinidad like a paradise. Rum and Coca-Cola, Golden Point, Pumana, both mothers and daughters.
We're so happy to have you back together. So my name is Todd Alonso. I'm a site PI at part of CDCES. I'm PCIndome medical director. I've been doing QI there for 6 or 8 years now. And so I have the rest of the panel up here. I'll let them introduce themselves as we talk. I want to keep an eye on the time here. So we're set about 37 minutes or so. And so what we'd like to do, I can hear myself. I'll try to ignore hearing myself here, but if somebody's able to mute that, sounds good. That'll please help me. We want to talk a little bit about QI leadership, and what we realize is QI is hard to do. So we're gonna kind of go through some questions. I don't have any disclosures. This is the group here that we're gonna introduce themselves. And so just the first statement is doing QI is hard. Who has dedicated time to doing this? Who has funding? Where do you get the money? We all wish we had oil reserves like right under our hospitals we could just tap. But apparently CMS doesn't think that endocrinologists do very valuable work, and we don't make as much money as, like, we need a procedure, like we need to do scopes, we need to do something. Our GI clinic has like 6 or 8 times as many psychologists as we do, and everybody sees a psychologist just to eat gluten-free. And we can barely afford one psychologist. And so let alone doing QI is really hard. So expertise, like, how many of you guys have actually had formal QI training? How many of you guys were just kind of thrust into a position where they said, figure it out? There's this, one seminar you can go to, and then you're up to speed. And how thorough was your training? How much of your team has been trained, or how much of your team maybe got trained with you and then they rotated out to another job and then you had to hire somebody else and kind of get them trained up. Data access is really hard for all of us, right? Like we really want agile, fast access to data, but having a dedicated data person is expensive. And so how do we get the access and how do we use the data? And then priorities is always hard because we have a lot of really great priorities in the exchange. But then there's also local priorities that maybe don't align, and it's all good work. But how do I prioritize what I really want to work on, and what do I have funding for, and what do people on my team want to work on? So I want to kind of talk through some of that stuff with the rest of the group up here. Obviously, it's all this work is worth it, right? Our patients definitely deserve better, and we are not satisfied with the current outcomes that we have in diabetes. So let me just kind of throw this out to the group here, and maybe, Devin, we'll start here and work our way down to Grace, and maybe have each of you guys kind of discuss this. Tell me a little bit about your team's structure, and then just kind of how you guys have evolved in QI over the last couple of years.
Great, cool. So I'm Devin Steenkamp. I'm the PI at Boston Medical Center and adult clinic. And so we're pretty new to this. We've been involved. Can you guys hear me? For just over a year now, with very little, like many of you, very little initial QI involvement. In fact, many of us, I did a residency program in QI, and then I had a QI expectation in my fellowship, and I knew what a PDSA cycle was basically, and that was about it. But this was important, and like Todd said, we had to do this, and we're all engaged. And I don't have to speak to the converted here. We're all engaged because we know this is important. So we got together and said, who wants to do this? And amazingly, we had more takers than what we ever would have experienced, which I think was, I'm sure many of you find that, is that once you start engaging people and you start wanting to improve things in the clinic, you actually find people that say, hey, I'm there, I want to be part of this. And our QI team started off with myself and Liz, who's here with us now, who's our QI champion, who's a dietitian in our clinic and our main pump trainer and diabetes technology person. And we now have 8 people, and we have a weekly meeting. And we just started with just the 2 of us and an idea. And now we have, if we're not there, that keeps going. And I think some of that's just being organic. I don't think we've necessarily gone out specifically saying, do you want to be part of QI? It's just been, this is what we're doing. And do you want to be involved? We've got this time between 9:30 and at 10:30 on Wednesday mornings. Here's the Zoom link. This is what we're involved in. And next thing, there's another person on the call and another person on the call. And we're surprised because we're not necessarily giving a lot of these people time or funding or providing anything, but they're engaged in the process and they want to be involved. And so ours has been very organic, and it's just been stuff that have been pain points for clinicians in our clinic. And it may be different from these guys, but it hasn't been something that's really required much structure. I think it's been a collaborative type of effort.
Yeah, it works. I'm Emily Coppedge. I am the chief nurse practitioner at Cornell Peds Endo. And our group is actually much smaller than some of the bigger places. So we're a much smaller team. And really how it started was me, an attending who's now moved away, and our dietitian. And it was like this threesome during the pandemic. And I think Dr. Foyer probably had QI training as a resident. Me and Isabel got onboarded through the exchange. And then we were off to the races. Our first meeting with the exchange was like a life lesson of, you are doing it wrong. Thank you, Ori, who was wonderful, but she was like, no. And so then we had to backtrack and rethink and fishbone and all the stuff. And thank you to everyone who had stuff out there that we could read, because we really went through other people's studies to be like, okay, wait, we are kind of trying to do that thing where we know what we're doing, but we really don't. And then it kind of evolved from there. I think what came on board is our team changed. Our nutritionist is on maternity leave. A doctor moved away. Dr. Ansel has joined. And then we started recently grabbing our nurses because we do a lot of general endo too. So they kind of have a split role. And so as it's evolved, all of a sudden we found that like, hey, this nurse has always been doing things. She speaks to our Spanish patients. She speaks Spanish and now she's involved. So kind of finding those. I think the evolution is QI, you see real-time results. So I think what's nice about it is that when you're on a call, we have a weekly call with our whole team, and it's like, hey, we're seeing these great outcomes. And all of a sudden it's easier to get people involved in doing our projects. I don't know, we're talking about funding. We have no funding. We're in healthcare. There's not.
Well, that's encouraging. You can do work and then still say, I don't have any funding, but it's, you can actually still do work though.
Yeah.
Alisha, how about like your team structure and function and evolution?
Yeah, so my name is Alisha. I'm the dietitian and diabetes educator at Grady Hospital. So it's a safety net hospital. Our PI is an endocrinologist in the clinic. And I think for us, it was also a huge learning curve. A lot of our endocrinologists that are part of the QI team are very research focused. And so understanding how different QI methodology is was very challenging. I think it took us about 2 years to understand that. But so we're pretty much the main part of the team. We also have a glycemic optimization clinic. This is where we see our adult patients with type 1 diabetes. And through that, we sort of recruited our providers. So we have 2 endocrinologists, a pharmacist, a social worker, and myself. And we've kind of just, inadvertently recruited them to be part of our team. And it's been super helpful to have their insight into what's most important for our patients and what we need to focus on.
How about you, Grace? Tell us about Le Bonheur and your experience there.
Yeah, so I'm Grace Nelson, the PI at Le Bonheur Children's Hospital in Memphis, and it's really me and my champion, Blake Adams, who's here with me today, who's a nurse by training. And so it's really the 2 of us at the beginning, a lot of support from the other attendings, or many of the other attendings in our practice, but sort of support from afar. Again, most people have a lot more research training as MDs than QI training. And so it was really us starting and bouncing ideas off of them. But honestly, Blake was one of the few nurses that stepped up to be the champion. We talked to a few of the other nurses in the clinic and everyone was a little skeptical at first, nervous about how much they'd be able to dedicate the time. They just felt like, nope, I have too much other stuff on my plate. But as we've moved forward, we've been able to get those people in, pointing out that a lot of the stuff they're doing is QI or could be done better with a little bit more of a QI lens. Like they're already trying to make things better. So, hey, why don't you do that as a smaller PDSA cycle? And suddenly they're on board. So it's been pretty organic in that sense of, but just lots of talking to people over and over and reminding them that we can take small steps. And it's like, it's okay, I'm not going to change your entire process overnight. Just like try this one time with me and see what happens. And so getting people on board that way has been how we've done it.
Okay, thank you guys. I want to, maybe pop around here and maybe not have all of you guys answer each of the questions. I think we've kind of already spoken to the third one where, growing your team is organic. And Dawn and I talked earlier about, having a core team who's very dedicated to QI, but it sounds like we're all kind of pulling people in from a clinic. And it sounds like everybody's, if you can find something they're interested in, then they're willing to donate some time. And that's sort of what I'm hearing. So what about the funding? Have you guys been successful at finding any money, even like a dime on the sidewalk?
Also, I kind of
anything, yeah.
Okay, so there, I had to do a shout out. So there's been a huge push at our clinic. Honestly, we're a separate payer clinic. We had 2 clinics. We had a Medicaid clinic and we had a private, and that was kind of our subspecialty. And then obviously that need to get fixed, and thankful some silver lining of the pandemic, we got that fixed. And so now there's this Dalio Center over at NYP and they have money for health equity. So we are learning, we might have options. And then the other thing for funding we see a lot recently has been that US News and World Report is what all the hospitals care about, right? And suddenly our QI projects are helping that outcome. And so if we're on a meeting and it comes up to US News and Report, they're like, well, we have money to help your outcomes because so that has been a new recent on meetings that we're seeing that we're getting a little more leverage.
Right. And so for the adult sites who don't have to do the US News song and dance the same way the PEDS sites do, the PEDS US News data is very data heavy, and our hospitals somehow have a gold mine to push those priorities, right? And then we can like align QI projects. Yeah. Grace, were you going to say something?
Well, it's very similar. The US News and World Report angle is like what I say constantly, like, but we need this for US News and World Report constantly. It's all I talk about really with like the other people, the higher up people in the hospital. The one thing we've been able to get a little bit of like community funding for some special projects that have come in and out. But honestly, even one of those bigger projects that we had that was working with like community outreach people, we had funding for about a year, and then that actually kind of dried up, but the hospital had seen the improvement with that sort of approach and has gone ahead and funded it. So that's even gone, but the hospital, I guess we've just been able to demonstrate that what we're doing is helping and those metrics are improving, and they like to see that too. So I guess we've just been leveraging that more than anything.
How about from the adult sites? Do you guys have any perspective on finding some funding?
Yeah, so I mean, we don't have any funding, but what we've done is we've leveraged the T1D exchanges funding that we got as the means to be able to protect time for us to be able to get the data that we need. And our hospital is a safety net hospital in the city of Boston. So it's not a diabetes center, and diabetes is not necessarily a priority, particularly not adult diabetes. And type 1 diabetes in an adult center is even less of a priority than type 2 diabetes. So you really just keep going down the ladder in terms of priority. But I will say that now that we're actually starting to get the data, which we never had before, and we can see the effect of the data, that's actually starting to make its way up the hierarchy. And so now, our section chief as well, type 1 diabetes, we're actually doing reasonably well with this stuff, and you guys are doing a good job. And now we have less pressure around RVUs and less pressure around other stuff because we're actually doing something here with this data. And we knew we were always doing stuff, we just didn't have the data to support it. And I think throughout the institution now, we're just going to have more opportunity to involve ourselves in some of the health equity work that the institution's involved in. So I see we've only been involved for a year, but I do see the potential for us in the next year or two to really actually make an impact. We're still trying to get data mapped, and we're embarrassed to say we're one of the few sites that are not data mapped. And the reason is our IT, it's not a priority for our IT group. They've got a long list of priorities, and homelessness and social determinants of health and those other things are higher up on the IT prioritization list. But now we go to the QI folks and say, well, look at our data. The QI leadership are very supportive, and they can put pressure on our IT leadership to be able to help us with the data mapping process. Versus in the past, I wasn't able to get any traction with IT. IT was like, yeah, we'll put you on the list. Maybe in 5 years' time, we'll get it done. It's not a diabetes center. That's now it's at the chief medical information officer's level because the data has supported us. So I see the potential for funding. And in honesty, that was the main reason that I wanted to get involved with the exchange, was we needed to have the data to support and advocate for internal change. Without that, we knew we were doing good stuff, but nobody else did.
Yeah. And Alisha, we're going to answer that.
Yeah, just really quick. I think that it's important for us to just be more strategic now about what projects we are prioritizing. And I think a lot of the projects that tend to cost the hospital money. So frequent readmissions with DK and severe hypoglycemia is something we want to prioritize now, because we know if we can show that our, QI projects are supporting that and improving that, then we'll definitely get backing from our hospital.
Yeah, I want to speak to that a little bit too. A lot of you guys I've talked to over the years and told you about our funding journey, and we've been able to be really well resourced. We have a foundation arm at the Barbara Davis Center, and then that's how it was started. But my career advice to any junior faculty here who haven't heard this before is have your ask in your back pocket. I'm looking at the fellow here, and you should have 3 asks in your back pocket with different numbers of zeros on the end of them. And I was really, really lucky, right place, right time a few years ago, when a dad came in as a front man for another dad, both of who worked in real estate. And one of them said, I know a guy and we want to fix things. And we said, what do you want to do? And I said, I want to hire an Epic analyst, basically is where it went. And I said, I need a 3-year commitment for, salary and benefits for an Epic analyst. And the answer was like, okay. I mean, it took us several months to get to that point. And then I hired an Epic analyst and was able to eventually get another grant to transfer her over. And having your own Epic analyst is like the coolest thing ever, because then you're not like taking a ticket and waiting at the counter, and then you come to find out like, oh yeah, we took that off the agenda 6 months ago. We actually weren't going to service that. And we didn't bother telling you.
I was just going to say, try Cerner.
Yeah. And so if you have Cerner questions, ask Mark over here. He's his traveling name is Mithrandir with Cerner. That's some of the work that they do. Okay, so we talked kind of 1, 2, 3. So data access is hard, especially if you're like taking the ticket and waiting. Have you guys found any creative solutions to data access, or just kind of being able to like get what you can get just for this project?
The get what you can get, like some of the stuff like the metrics that we've looked at has been like, okay, what's something that like Blake and I can pull and look at? Like, no, it's not the whole clinic, but it's okay, these few clinics, what are our numbers, or who's showing up for these things? Let's keep our own registry of who we're getting on CGM. And some of that we're doing for other reasons in the project, but making sure to do it sort of strategically. So it's like, well, if we can't get the big numbers, at least we have little numbers that we can keep track of what we're doing.
How about like REDCap surveys? Do you guys ever use that to get patient entered data? Just like I can throw a REDCap survey out even if I can't get an Epic build or a Cerner build.
I know we looked at it, but then it became extra work on top of it. And then it just became one more thing. And then
Yeah.
it was like, now we have a red cap thing, then we have this thing. And so it hasn't really played out for us, at least for us.
Yeah, so I think for us, we're using Slicer Dicer in Epic. So while we're kind of waiting for our IT team to do the data pulls that we're requesting, we're at least able to get gross data on our type 1 patients in the diabetes clinic and start with our projects using that gross data and then kind of getting more specific whenever that ticket is pulled.
But sorry, I brought this up with Dr. Gallagher and I were talking. We've run into issues because from the US News and World Report, they'll pull data and then ask us to verify it, and it's wrong. And that's an Epic pool. And there's so many times that they pull that data, and I'm like I have the data of my own now, and it's wrong. Like, and I can show you where it's wrong. I'm not just making it up. And so I think that's been an issue too. Is they'll pull something and we're like, that's not even right. So that's a bigger issue. But
How many of you guys are on Epic here? Okay, how many of you, keep your hands up, how many of you guys have somebody on your team who is really facile with reporting Workbench in Epic? Okay, so some advice that I would say is, so right, we don't have a lot of hands up. How many of you guys even know what reporting Workbench is in Epic? So reporting Workbench is a self-service reporting tool. And if your center is really uptight about data, they might really restrict what you can access. I've seen that at some hospitals. But I would suggest that if you have somebody on your team who wants to be your data pull person internally, to go ask your Epic people, I want reporting Workbench training, and have them put you through some training, some of which will actually be pertinent, and some of which is a waste of time, like most EMR training. And then they may give you access to be able to pull some reports. And the way you can do it now is you can build a report and then you can share that with somebody else. And so back to the funding piece, if you have a research team who wants to recruit 12 to 15-year-old girls on insulin pumps, your QI person could build them a report and share that with them. And then when it comes around to like, I need some help from the research team, like teach us how to make red cap surveys, then sometimes there's a little bit of payment in kind. That's some of the ways that we've had some solutions there. I don't know about the service, like self-service reporting in Cerner. I don't know what kind of access there is, but whatever. Yeah. But sometimes if you like keep asking the question, like you ask your mom and then you ask your dad, like when you don't like mom's answer, sometimes that actually works with some of the tech answers.
Yeah, I'd just like to add. So we tried the Workbench reporting in Slicer Dicer, and we were, we got one of the Epic folks to actually build us what we thought was this really elegant report, and we even got antibody data and C-peptide to make sure that we were actually, because we do that a lot in our center, just because we have a lot of heterogeneity in our type 1 adult population. A lot of people we think got type 1 and don't, and vice versa. And when we actually initially started reporting that data, the numbers were totally off. And so then we actually just had to go in individually. And so Liz has been doing that and individually going through charts to verify that even when we were using our med list for CGM prescriptions, this prescription was sent, the patient never started using the CGM at all. And so we weren't really interested in who was actually actively using the device. So still today, we're actually going in and manually checking every chart every month to make sure that the patient's actually still using the CGM device. So when we looked at our initial data, we reported our CGM rates were down here, and I said, that doesn't make sense. And then when we re-looked at it manually, the data was what we believed it was. So we're still there. We're still actually having to go in and manually check stuff, which has always given me concerns around using Epic and Slicer Dicer and the Workbench reports for accuracy, because it's really the quality of the data that's put into that that's the most important piece.
Garbage in, garbage out, right? We found that one of our biggest pieces of success is if I'm going to ask my colleagues to document something during the visit, I need it to be immediately useful to them in the visit. And then I get to use the data on the back end for research and QI and everything, but I have to give them some benefit. So we have built out flow sheet rows. And I was just telling Joyce earlier that we created some rules where if you click CGM yes, and you don't fill in CGM data, when you go to navigate away, we built a rule that the chart, that Epic says, wait, soft stop. Are you sure? Or if you click insulin pump, or if you click, they're on an MDI, but then you click an insulin pump, it's like, wait a minute, that didn't make sense. Are they on MDI or are they on an insulin pump? And so you can create rules, at least within Epic, and I'm sure Cerner has something like that, that it drives people to do things. If chief complaint equals type 1 follow-up and type 1 does not exist on the problem list, hard stop. You can create that rule as well. Because some of us have colleagues who don't ever put things on the problem list, right? And then your date of diagnosis, and then what diabetes type did they have? But there are published algorithms using EMR data for differentiation of diabetes, yes, no, and what diabetes type. But you can actually drive your colleagues to better documentation, but you can't piss them
Just
off.
need your Epic analyst.
Yeah, but you need an Epic analyst, right? So, but you have to prioritize like which things are you going to push for, and what's our biggest pain points. Okay, so I asked this other question here. So pitfalls, I feel like sometimes we are asked to fix things and fix too many things, like it's overwhelming, and we don't QI it. Like we just stick a Band-Aid on it. In a year or two, we're going to fix it again, and then we'll fix it again, and then we'll fix it again. How do you stay away from that? How do you actually do QI on those things? Can you think of any?
I mean, I always have something to say.
Yeah.
I don't know if it's useful. I think what we learned, I feel like, especially in our first few QI meetings with the exchange, was start smaller. And I think that does answer this question, because if you try to fix the whole problem, unless you have a whole lot of funding, and even then it might not be the right answer, right? Like if you just, because how do you know if that's going to work if you just are like going to change it all? So if you start small and like, well, how can we do this in a way that we try it with a few patients and then see if that works, see what the problems are, which feels weird, right? When you're used to research, it feels weird to try it in like one clinic and be like, I'm going to decide if this worked or not. But you can do that systematically. You can take the data down and figure out, okay, why does that feel like it didn't work? Why did it seem like it did work? Okay, now let's expand it to a couple more clinics. Now let's expand it to a couple more providers. Obviously, some things work better than other problems to do that approach, but most things you can break down at least somewhat. And I think that really helps to avoid the bandaging, because you are thinking through it and taking one step at a time, so that, you know, and avoiding the answer of just let's re-educate, right? Re-education sometimes needs to happen, but it shouldn't be the first thing. And so like, what small things can we do to force a difference? Like you're saying, of forcing forcing our colleagues to enter everything, that sort of thing. But starting small, so you know the change is real.
So small tests of change, that's definitely a real QI principle, right? And then piloting, pivoting before you scale.
I think the other piece that I would add is that I think if we become, while I agree with the small tests of change and just being iterative is really the way to do it, I think we have to take some time at the beginning to think about what our ultimate goal is. And really, even though we know, say, we want to increase CGM use in our population, that's like easy, broad goal, but what does it actually look like in the detail? And actually kind of planning out those fishbone diagrams and those key driver diagrams, so that you kind of know what needs to happen here in order for that to happen, for the next thing to happen, for the next thing to happen. And we spent some time in the project we've worked on in the last year really thinking through, we couldn't do that unless we did that. So that was the first iterative change that had to occur. Like we wanted to increase and reduce our disparities in our hybrid closed loop using population. We just, even though we take care of a minority population, very underserved, we had a very low pump utilization for those who are publicly insured and very high for those who are commercially insured. And we were like, this doesn't make sense. This is not the population we're taking care of. But it doesn't help us to just have the big goal without actually saying, why? Like, why is this not happening? And we had to go and find some data as to what we were doing wrong. And then I think that avoids the bandage, is if you actually plan everything out and think about where you need to get. So for example, we said, well, we've got to increase our access to trainers, and we just didn't have enough access. So it doesn't say go and put everybody on a pump if there's no access. And so the bandage is fix the access, but that doesn't get you to the ultimate outcome, which is where you want the patients to be using the technology. Because once you get the access, what do you do beyond that? So I'd say that was one of our major learnings, is you'll get stuck in bandage mode if you're constantly just thinking about the next step, because that's the bandage. And then rather, how do I get there in a couple of steps?
Yeah, so applying some real QI principles. And do you have somebody on the team who kind of helps kind of recenter the team around that?
Yeah, so we meet every Wednesday, like I said, for an hour. And that's been amazing. It's been a really fun time because it's just problems, operational issues that takes up some of that time, and just where are we having pain points? And then, okay, wait, what's the big picture here? Like, let's not just get bogged down, which I think is your next question, Todd, around you can get bogged down in the operational demands, but kind of having the big picture and just having regular meetings, I think has been really good for us.
I would say regular meetings My counterpart who did a lot with me is on maternity leave, but we met every Tuesday. And it was that moment of being like, we actually had to stop one of our QIs because we actually got too successful and we ran into an access issue. Just because with people leaving, and we were like, okay, now we got to pause. But we were able to say like, hey, I'm having this issue. And it was just good time to think through it versus just being like a month later being like, oh, is this working? Like that part. I think the regular meetings really help.
Yeah, so we have about 10 minutes or so left or until Osaki cuts us off. So I just kind of want to go out here. I see a hand up. That's exactly, you're reading my mind. So like what kind of, issues, and we're bringing a mic over so the folks at home, can listen and hear what we're saying. But what kind of QI issues, I don't know, do you have, in terms from a leadership, like where are we having challenges? Where are we? Did you have a question here or sorry?
It was from a virtual participant.
Oh, okay. Yeah, that'd be great. When can we start there?
Is anyone using the Healthy Planet module in Epic for data?
Is anybody using Healthy Planet? Yeah, so Rona, Texas Children's, Anna at Cincinnati, and then who's your group back here? Atlanta. So there's some groups in that. Does anybody want to speak about how Healthy Planet helps you with some of your QI initiatives? And how you're able to leverage that? So Rona's like pointing at Sarah. Sarah doesn't see her pointing.
We have a registry built through Healthy Planet Diabetes Registry, and so that really drives our clinical work day to day, because through that we're able to see when clinic appointments are, and then pull all the metric, like all important aspects of the clinic appointment. So whether or not they're due to meet with a diabetes educator, whether or not due to meet with social worker, that type of details. Is there any gaps that they're doing for screening labs, those type of things. And so it really drives our clinical day-to-day operation and at a more population level for all of our clinical locations.
So I'm not familiar with that registry function. I know our type 2 clinic uses it. Do you have to manually put each patient in the registry, or is it based on diagnosis?
It's so for us, it's based on a diagnosis it's based on a flow sheet entry that we have.
Okay.
So there's a
Like put
built
them
into
in the
our clinic
registry.
note. Yeah, if you list if it's diabetes, then your required flow sheet that it auto populates into this along with other metrics.
Okay. Do we have any other at-home questions? Okay, that was it. I see another question over here. Yep, or right over here. Yeah, thank you.
This is Grazia Aleppo from Chicago. So one thing that I found to be very challenging is the documentation in Epic. Once I started working with the QI collaborative, and for example, for CGM, some of our patients do DME, so it's not in the medication list. And then we don't even use the Z code to say the patient have an implant. So it is so we're trying to teach our colleagues, that's the hard part, to put those codes in, but it's pretty manual. So I found to have Epic, to see Epic very inefficient approach. I don't know, we don't document right. And that's my concern, because we have a ton of patients on particular tools, but I bet you when we get the data, it's not gonna look right. So I don't know what to do to fix it. Meaning, how do I get the right data in?
We got a smart form built, and this was pre the QI we're through New York Presbyterian. So they ended up with the smart form for us, which was nice. So it's just T1 diabetes, and it has all that information, because we ran into the same thing through, like 50% of our patients were DME until recently. So at least we had a way to put that information in. We actually thought it wasn't all pullable, but we learned, thank you to our recent pull, that it is pulling, like even when we've written stuff in. But that takes time and finding someone to do it. So that's not an easy answer, but.
And there's smart forms in Cerner as well. That's what we're switching to get that stuff, but just for any Cerner sites out there.
We also had a similar challenge, but with actually the help of Todd, we were able to create a flow sheet to gather that data. Right now, our challenge is how we're going to get our clinic to fill that out, just because we're so short staffed, but that's going to be the next step in implementing that.
So we don't use flow sheets. So what we've done, we've just asked everybody, and we actually presented it at a faculty meeting, and we sent it around as like a policy that if you're going to put somebody on CGM, whether it's DME or not, just put it in the med list. And then even if it doesn't go, you don't even have to send it to the pharmacy. It's in the med list. How well it works, I think it works better than it did. But the other way of doing it is then just going in and then looking at the individual charts, which is not perfect. But that's one way everybody is on CGM on the med list.
Yep. I just want to finish the thought there. So what we did in terms of like using it in the moment. So I commandeered the note templates. It was the Wild West for a while, and our note templates were a mess and they took forever to fill in. And you can create rules in Epic. And so if CGM yes, then now you can put some code in your note template. If you go onto the user web and look up our note templates, it's all code. It looks crazy. Just how much we put in there. So it pulls a flow sheet entry. It pulls in the name of the CGM, and it says he's using a Dexcom G6 or a Freestyle Libre 3. He says that in my HPI, so I don't have to free text that. It's like my HPI is actually filled out, and it looks like prose because I clicked a button. And then all the CGM metrics pull over. And then if we wanted to build the 95251 CGM interpretation, there's a chunk of text that shows up if I click CGM yes, and it's down at the chart trash section that like no PCP is ever going to read. I think I'm just going to title that chart trash. Like this is what they say I need for billing, but it's that standard language. So nobody has to memorize a smart phrase. Nobody has to do anything. And I think my colleagues don't even know it's there. But if they click yes, then it shows up and it says whatever gobbledygook that they need. And then you can build, if we were going to build a 95251, which we're not currently doing, but at least gives us that opportunity to pivot. You have a question over here? No, I'm done. Yeah.
I wanted to speak to a little bit about managing a process without a quick fix. At Cincinnati Children's, what we found so helpful is really at some point at the beginning or midpoint, whenever you have bandwidth, is really improving the QI capability and capacity of your team. At Cincinnati Children's, we're so lucky to have like a dedicated QI department. We call it the Anderson Center. And I know a lot of other hospitals don't necessarily have that, but I think the more time you can spend really learning the tools, you're not going to go wrong if you do that, and it will really help a lot. So like if you can know what is the current problem, right? Like what is the current process, and using QI tools, the fishbone, the process map or 5 whys. And then I think if you can build your theory for improvement, like what do we think could make a difference? And the more really skilled you are at using those, I think it won't just be a quick fix, but like you were saying, it'll get to what the real problem is. And then even still within our hospital, though, we are like so careful to use the QI methodology, but even still, if you take your eye off the problem for like a minute, a day, a year, the problem will reoccur, right? So I think that's when using the high reliability intervention, so that when we take our eye off of it, the intervention still happens seamlessly, like trying to make it the easy thing to do, the right thing, where it's the default.
Yeah, Amy, I think that's absolutely right. That education, I think one of you guys mentioned, education is like the least effective QI method, because you'll just educate and re-educate, but make it like hard to deviate from the right path where they have to actually work to break it.
Yeah, right.
As long as you don't drive your colleagues nuts with extra work, like make it easy and smooth and well paved.
And I think the IHI Open School has a lot of really good modules on there that anybody here, I think, has access to it. And also at Cincinnati Children's, we do QI classes that we offer to, I know people here are actually taking it right now. So hook us up if you want to do one of our QI classes, but Open School for sure. IHI is a great resource. Before I got this job, I used it like when I was in school. So
that's a great comment. Thanks, Amy. Do you guys, I haven't looked over the side of the room. There's like things in my vision, so I forget that there's another side of the room over here. Yeah, there's one over here. Yeah. I just wonder, should I jump off and run, or should I just stay in the seat?
Carol Levy, New York. Sorry, I talk a lot. First of all, that Selassie and I, who's an MPH and I'm leading our project, we're very invigorated by everything that was said here. My problem now is, how do we get this done and what's the cost? So I loved Healthy Planet, but I'm guessing Healthy Planet costs money. I love that you set up a flow sheet. We, like you, Devin, have been for the last 10 years fighting with our institution to get a flow sheet started. how did you push them to start that? And it's not that Mount Sinai is a piece of garbage or anything. It's just that, it's just hard to get things moving when diabetes is not the primary institutional priority. So how did you actually do this? We do not have the bandwidth to have somebody manually review all these charts unless I can get some medical student to do it. But how do you get people moving? That's my question.
I think that you just have to show the data. I think you've got to get some data to show the power of the data. That's the main reason. And maybe that's been validated for us that we joined, is I didn't know how to get the data. And so we used the money that the exchange provided for us to get the data. And then now the conversation's different.
Yeah, as far as a flow sheet, if you're a physician builder, which takes an investment to go do to get the certification, a physician, you could actually build your own flow sheet for your clinic. I'm not good enough at it, but I know how to communicate with my analysts. That's what my skills are for. So you could brute force it if you could get somebody to get that.
We have people that probably could build it, but then once again, they don't have the effort to build it.
Right.
This is that
Yeah,
catch
when am I gonna get it
22
done?
that all of us get into. But no, this is really exciting because it's giving us some great ideas. So thank you.
And I saw another question back here. Thank you. And so do we have Osagi, do we have time for maybe 3 minutes? Is that 3? Okay. Yeah, Mary Pat has a question.
Thank you. I have a question about how you integrate your family partners in this process, because it's a little bit challenging to meet every week and then do quarterly meet with your family partners to see what their thoughts are about these QI projects, because a lot of what we're interested in is how they feel about all of the things we're doing.
Anybody want to speak to that?
We have quarterly meetings with family partners. That it's actually a whole clinic thing, so it's not just for our QI project. But then I've also just gotten really good at just asking those questions as part of my workflow, especially for whatever projects, like in those beginning stages when I'm the provider doing that. And so yeah, just asking and not necessarily asking them to be at the meeting that they may or not be able to reach and all that stuff, but still using that, their input.
Can I ask that a little differently about family partners? One of the challenges that we face is the family partners that we think of first are white, privately insured families who may easily have the bandwidth, but how do we include like a diversity and equity?
And that's where I feel like I get my best chance at getting a diversity, because I'm going at my patients that are maybe unhappy, maybe frustrated. I hand them some survey that I want them to do, and hey, what did you think about the survey? And if they're like, well, it was annoying to fill it out, or they like fill it out kind of funny. And I'm like, tell me more about this. I'm trying to learn how to best help, like, what's worth doing, what's worth not doing. Can you tell me a little bit? And it takes some more time. I don't have time every clinic to do it. But I get a lot of information from it, just asking and taking notes on it, and then, putting it into our PDSA cycles and thinking, okay, let's get a few more and go from there. And that's how I feel like I get more diversity of like sort of targeting those patients that are struggling for a variety of reasons.
So I can add something. What we did was we tried to leverage the QI process to do qualitative research. And so for the project we've been doing for the last year, we've actually had a study coordinator that was funded to actually go out and interview people going onto hybrid closed loop. And this was particularly the high risk population that we were aiming for. I think she's interviewed about 20 folks now. It was incredibly difficult for her because many of these patients just didn't want to talk, or it wasn't the right time, or something came up. And then also had survey instruments before they went onto the system, and then a couple of months later. And so we leveraged the project that was already happening, and we were already doing it just through the QI process to link that to research. And I think that's been something that we'd like to do more of. And that was Todd was mentioning that earlier, is QI creates an opportunity for subsequent research, and that's what we found, and that's how we've done it.
Alisha, do you want to answer that, and then we'll kind of close out?
Yeah, absolutely. So for our institution, when we first started, we did focus groups with our adult type 1 patients, and then we were able to identify a QI champion, and we really heavily rely on our patients to kind of drive what our projects are. I think we talk about implicit bias, and I think a lot of times as providers, we think we know what our patients are struggling with, but we need to hear it from them. And so that's really what initially drove a lot of our projects to get their buy-in also.
All right, thanks. So I think we should probably wrap up there. Thank you guys very much.